Well, as a few more people are coming on, I'm sure there will be more. I'll just start with introducing myself. Most of you probably know me. I'm Dr. Jane Mahoney, Director of the Dissemination Implementation Launchpad at our ICTR, UW-Madison Institute for Clinical and Translational Research. And this is our DRISS seminar, which stands for Dissemination Research and Implementation Science Seminar, which we host monthly during the academic year to preview the growing science of D&I research and practice particularly on our campus. This seminar is open to all, and it is part of our iShow certificate. I'm starting with the acronyms, but iShow stands for Implementation Science and Community Health Outcomes, which is an ICTR certificate, which addresses the gap between basic research discoveries and their application and clinical and public health practice. So I have the honor to introduce Ed Portillo, who is going to be doing the last of our series today, and not just is it the last, but it's probably going to be the best instance you can find of recent use of D&I science on our campus to scale up a pharmacist-driven COPD care service. So Ed is a clinical pharmacist practitioner at the William S. Middleton Memorial Veterans Hospital and an associate professor in the School of Pharmacy here. And he is leading efforts to evaluate the national scale up of this model, which he developed, which is now in over 30 VA medical centers across the US. Congratulations. And congratulations to the veterans who get to benefit from this. He currently practices in pulmonary medicine, and his teaching and research interests emphasize pharmacist integration within rural healthcare delivery models using D&I science methods. Ed, we're delighted to have you provide your presentation today.
Well, my goodness, Dr. Mahoney, I am not worthy of that wonderful introduction. Thank you so much for that. And really to everyone, thank you for the invitation. Thank you for logging in. You know, here we are, if you're listening to the recording in beautiful May weather. And I do really appreciate everyone's engagement and time and the invitation. So today I'm going to talk through expansion of a program that I developed way back in 2016, 2017. It's called COPD Care. We'll talk about the program a bit. And really, this is a journey of the program. It's also a bit my journey to D&I, right? Dissemination science. And one of the themes I hope that I can relate throughout is just the exciting field that is D&I and how the tools and resources can really be leveraged to scale up and inform the scale up of promising practices like COPD care. So again, thank you. And my goodness, Jane, with your nice introduction, I don't even need this slide, but yes, I'm a pharmacist clinician. I practice in pulmonary medicine. A lot of my work is in that T3, translation of evidence-based care delivery to routine care delivery to practice. And my focus areas in pulmonary medicine and in rural practice settings. Whenever I talk about my work, I really think it's important to start with the why. Why do we do this work? Why do we get up every day and have all these meetings and do all this work? And our why really is for Warren. So Warren is a veteran. He's retired in his 60s. He has 3 adult children, and I speak to Warren quite often. And he told me recently, I'm really grateful. I'm grateful for everything I have. I'm doing well, and that made me happy, right? But Warren does have one challenge that's really important to mention, and that he is a veteran with COPD. The mortality rate for patients with COPD after a disease flare, is over 50% within 5 years. Think about that, over 50%. COPD is the second leading cause of hospital visits in VA. And unfortunately, the prevalence of COPD is threefold greater among our veteran population compared to civilians. In fact, 1 in 4 veterans suffer from COPD. This disease is the third leading cause of death in the United States. It affects 15 million Americans, and the prevalence of COPD in the civilian population is nearly twofold greater in rural communities compared to large metro centers. So disproportionately, this disease affects rural patients, right? And the mortality rate from COPD has doubled since 1969. The excess deaths from this disease continue to increase in rural communities. And so we feel our why is that for Warren, care can look different and it should look different, and that Warren's future does not need to be defined by these statistics. So today, just for some themes, I'm describing the problem, right? COPD, a global killer. I want to then shift to the gap, right? So what do we know about COPD? What are the best practices we can consider versus what's happening? I'll describe a model that I built way back in 2016 and have been working to scale using dissemination science and now to translate. So let's go to the gap, right? Let's talk about the gap. And this is like going back in time, right? So 2016, I was a resident in the VA, and I know with dissemination science, we always think about, what are some of these external factors, right, that can affect scale up, implementation, motivating factors for our work. And there certainly was one in 2016. That was the year COPD was added to the Hospital Readmission Reduction Program for CMS. So for the first time, health systems were being financially penalized when a patient was readmitted with a COPD exacerbation. We were now tying the funding to the disease post-discharge, the disease progression. That was a big deal. And so I wanted to respond to this. And certainly in the VA, right, we've been working on these quality measures for decades, but I sought to develop an integrated COPD program. And I thought, I want to make this unique and really make this team-based. So I sought to integrate pharmacists as prescribers, as disease state managers on the primary care team for COPD. There were challenges, though, with this, right? And so I want to outline those. First of all, we know that half of patients for COPD do not receive guideline-driven treatment. And in fact, some studies say a third of patients only receive guideline-driven treatment. 85% of patients do not use their inhalers, their medications, as prescribed. So even if we can deliver the best practices, 85% of patients are not using their meds correctly. And when we've looked at the implementation work for COPD, there are some great examples of small-scale implementation work that's happening. But what we've seen time and time again, and I know many of us can state this for our own work in different areas, when these pockets of innovation are scaled out, the effectiveness, right? The effectiveness of that work is often not sustained. And certainly we're seeing that for COPD. So this was all going on back in 2016. What's happening now? Well, just recently, the American Thoracic Society has a report saying we continue to lack consistent approaches to improve readmission rates. CHEST, the world-renowned journal, there continues to be no single intervention that reliably prevents readmission. So this problem continues, and it's being written about and described extensively, leading to the first ever national blueprint for COPD for the United States. This is from the NIH, the National Action Plan, a call to action for all of us, researchers, clinicians, policymakers, to really tackle this devastating problem, right? And so I'll describe now the work that I'm doing, and this is one small piece to a larger puzzle, right, for this action plan. But I'm happy to describe it today, and very excited to hear your thoughts and questions and ideas. So back in 2016, the idea of this integrated care model really wasn't, there weren't a lot of examples of this back then. So I had a lot of questions. What does success look like? Is this actually possible? Who would I include in this model? What would we do in these visits, right? Like lots of questions. And, it's true to D&I, right? Like there's stuff written about this, but it's not always happened, right? And so there's an international guidance document that's published every year and updated. It's called the Gold Report. And they detail in there best practices that should happen after disease flares, providing tobacco cessation support, vaccine support, reviewing inhaler technique, optimizing treatment, right? Individualizing care delivery, referring to really important services to improve exercise capacity, like pulmonary rehab, right? So these are all written about and described. Yet again, we're not seeing this occurring in the United States and other countries, right, globally in a widespread manner. And so the goal for COPD care was to help move the needle. So COPD care stands for chronic obstructive pulmonary disease, or COPD, coordinated access to reduce exacerbations. And my goal was to implement this in 2016 at one clinic. And the idea was, again, that Warren does not need to be alone in managing his disease. He has a team. And that team includes his primary care pharmacist. This is one of my actually graduates, Dr. Cassie Sedgwick, who's amazing pharmacist. John Thielman, a nurse, right, in clinic, and his primary care provider. So this team is working collaboratively to support Warren. And we're specifically doing this, the vision was after a discharge. So after that disease flare, that severe exacerbation, how can we provide optimal care? So we're starting with some treatment education at discharge. All veterans receive a phone call after a hospital discharge from a nurse. And I thought we could really optimize that visit, right? And really provide some disease state assessment there, leading to a wellness visit. And I want to really focus on this wellness visit because here you can see Dr. Sedgwick, our pharmacist, and John Thielman, our nurse, and they're over here and they're providing optimal care delivery. They're reviewing inhaler technique. They're optimizing therapy. They're providing written action plans. Spirometry is being completed. And it's really packaging these best practices into this comprehensive visit within primary care, within Warren's primary care team. So he's not leaving his clinic. He's not leaving his usual care delivery team. It's just that the approach taken is more holistic and it's integrating team members. Warren also is going to get an action plan. So, when Warren's home and he's having these symptoms, he knows what to do, what to take, and when to call. Most importantly, when to call. So that's this wellness visit, right? And so we have the discharge, a phone call, a wellness visit, leading to a follow-up visit. And this follow-up visit is all about following up on the interventions made. And I remember attending one of the short courses years ago, and I had the opportunity to engage with one of the presenters and share this work. And I was told, this was 5 or 6 years ago, told that follow-up visit's really important because we see in the D&I field, we make these interventions, but if the follow-up's not there, we don't know if it's actually going to be carried out. So I really was focusing on that follow-up visit thanks to the short course and the mentorship I received. And this leads to then an annual visit with the primary care provider. The really neat thing about this is now the primary care provider has tools, resources, data, a plan in place to react to and to respond to as this individual moves the care team forward. So I have a few just quick evaluations to talk through. And the first one was feasibility. Like, this is all exciting on paper, but how do you take that and translate it to practice? So this was done way back in 2016. If someone said to me in 2016, you should use dissemination science, I would have said, what is dissemination science, right? So I didn't know a lot of this stuff back then, but I knew that you have to pilot test things, right? So I tested this out and I wanted to just look at, is this possible? What interventions might we see with this work? And how would this affect timely access to care, readmissions? Would it? And we're just going to do this and test it out in one clinic with a few of my colleagues. And we're going to just try it out with a few patients, 15 to 20 individuals. And what we saw was really interesting. First, the interventions that we were making were pretty exciting. Half of patients received referrals to additional services, tobacco cessation services, pulmonary rehab. 21% of smokers were willing to quit at that visit. Wow, that's a big deal, right? We were able to adjust treatment for over half of patients. Now, granted, not everyone needs treatment adjusted, but we saw opportunities for that in over half of our encounters. Inhaler technique. Half of patients needed their inhaler technique corrected by their pharmacist. A big deal. Readmission. So this is the comparator group in gray. Again, this is a very low number of people, right? So we saw around 12% of ED readmissions, 9% of hospital readmissions within 30 days. We didn't have any. Again, exciting, but a very low number of individuals received this practice. The follow-up, though, I really thought was promising. So we were able to see 73% of our patients within 30 days, compared to only 40% that didn't receive the intervention. I thought, wow, if we could even just scale up the idea of best practice delivery and follow-up, timely follow-up, that's a big deal, right? And that was promising to me. So then I started thinking, all right, how do you scale this? And where do I go from here? And thank goodness that next year I started here at University of Wisconsin-Madison with my teaching and my research. And I was introduced to ICTR and the Dissemination Science Launchpad, and things just got really exciting from there, right? Because the VA is a huge healthcare system. It's the largest integrated healthcare system in the country, in the United States. There's over 170 medical centers, over 1,000 clinics. We serve over 9 million veterans. It's a really exciting place to work and to be a part of. And for rural veterans, right, we know that a quarter of the veterans in the VA live in rural communities. And there's some unique, just like in delivering rural care in outside of the VA, similarly, there are unique challenges, right, for our patients that live in rural communities. And one of the things I was wondering, even early on in my work, was how can we leverage a program like COPD Care to help our patients that live in rural communities? The challenge is the VA is huge, but unfortunately, it's not uniform, right? And so we have this saying in the VA, well, when you've seen one VA, you've seen one VA, right? So basically, every VA is different. Now, there's a different culture, different programs that are offered, different staffing models, different levels of complexity, different local policies are enacted, processes, and needs. So while it'd be nice, right, to just copy paste a program across VA, that's just not how it works. It isn't. And so I had this question, like, how can I train colleagues across the United States and the VA to implement this practice? Would there be interest in that, right? And what would that look like? And of course, the issue is I can't be everywhere at once, right? Like, could you imagine the flights? Could you imagine, right, going all over the place and doing this? And so D&I, dissemination science, was really important to me because it got me thinking about this idea of, well, how does a health system adopt a practice? What does implementation look like? How do you sustain these practices? Thinking about that early was important. And I also was introduced to this idea for the first time of hybrid trial designs. Hybrid trial designs, what is that, right? And so there's 3 types. So hybrid type 1 is where we're really focused on effectiveness, right? We're really wondering, does this intervention lead to greater effectiveness? And we're not as focused on how something's implemented. We're more wondering, gosh, is this even gonna potentially work? And for me, that meant, patient impact for COPD care. Is there impact, right? And I'm not focusing as much in a hybrid type 1 about strategies for scale up, but more just impact. And you could argue that small scale work I did early on was sort of like a hybrid type 1. It was, hey, is this working for patients? Like, are we seeing good outcomes, right? Even early on. Hybrid type 2 got me really excited. So this was looking at effectiveness and implementation at the same time, right? So not only is this program leading to positive impacts for our patients, really important, but also what strategies are we using for scale up? How can we further optimize these strategies to provide greater expansion opportunities, right? So that was really the area I had not explored yet. And then hybrid 3, we're looking really heavily at implementation. So we already have that effectiveness data, and now it's all about scale up, right? And how do we do that with our implementation strategies to optimize the scale up process? So I was really interested in hybrid type 2. I was meeting with the Launchpad, using those amazing ICTR resources to try to make this happen. And I also realized I needed some funding, right? So that's important. And so that's actually an implementation strategy, right? Obtain funding, right? So the VA has this really awesome program. It's the Diffusion of Excellence Program Office. it is one of the most exciting things I think happening in healthcare, because what they do is they seek to take promising practices that are happening on the ground by frontline clinicians and scale those practices up using D&I approaches, which is so neat. So what are these great things happening across the VA? And let's pair that local innovator with another VA that has a strong interest in adopting the practice, right? So it's all about pairing the wants and needs of VAs with local clinicians, local individuals with hands-on experience, right, to provide that support. Really neat. So I submitted a grant for this back in, I think, 2017, 2018. It was reviewed by subject matter experts. There were 2 rounds of review. Here's the unique thing, right? And this is sort of where things deviate from a grant you may apply for outside of this mechanism. You actually, if you're a finalist, present at a live Shark Tank competition. Could you imagine having that for your grant, right? Like, oh my gosh, I'm presenting something. And then medical center directors bid on your work, right? Like, hey, I want this practice at my medical center. And then there's a promising practice designation. So my year, there were, over 600 practices that applied. Over 400 were evaluated. There were 100 semifinalists, 19 finalists, and we pitched it. We did our Shark Tank presentation, right? And we were very, very grateful and honored to be one of 11 practices selected, because there is just endless talent in the VA, and to be selected, for my team to be selected, was a really big deal, right? And so that led to this eval, right? So let's test out these implementation packages, and you know what? Let's do this in a way where we're also looking at effectiveness. Let's do a hybrid type 2. And so again, boy, was ICTR helpful for this in the Dissemination Launchpad. So this was the paper. It's evaluating an implementation package to deliver COPD care. And I'll mention that the lead up to this paper was pretty extensive. And so I won't be able to go into everything today, but I had a lot of structured interviews that were conducted, and pilot testing and refinement of this package locally here in Madison before we took this to a national stage and used it to implement, right? But when we got to this point, I wanted to know 2 things. First, like, what's the impact of this implementation package, right, on evidence-based interventions? Like, is it going to work? And 2, what do the end users think about it, right? So those that are receiving the implementation package, do they like it? Do they not? Like, how can we optimize this implementation package? And so for this work, I really leaned on a framework called Replicating Effective Programs. I love this framework. It's awesome because it's really intuitive, and it focuses on training development, which is exactly where I was in my journey for scaling this practice. So I also liked REP because they actually call out in the framework, this has been used in non-academic medical centers extensively. It's been used in rural community hospitals. It's been used in rural clinics. I thought this is a great fit for my goal of optimizing rural care delivery. And it really focuses on clinician self-efficacy. There's 4 elements of the framework. There's preconditions. So the first thing is, like, is there a need for this? Is there a local desire to do this work? And that's where the D&I, the VA, I should say, did that job sort of for me in selecting a VA that wanted to do this, right? That was great. And this was in the Mid-South. It was a different area of the country. It's not the Midwest, right? And it was a great, great area to work with, a beautiful area. That led to pre-implementation. So how do we refine this package, pilot test the package, and how do we implement this? Like, what's that going to look like? How do we measure that implementation process? And how do we sustain the work? How do we refine the package? How do we reproduce this package for more of a national dissemination? Again, I did a lot of work locally with work groups trying to figure this stuff out. But when I implemented the practice, I was really worried about failure, right? Because, like, the first time you do something, you want that. Like, it's probably healthy, right? As an evaluator and as a scientist and as a clinician, when you do something, you go, okay, if this doesn't work, why, right? And so I really appreciated Dr. Nola Proctor. She was a recent keynote speaker at the D&I conference right here in Madison. But the short course, but she really nicely described two different types of failures. So there's treatment failure, meaning there was something about this new location, right, where the intervention, COPD care, just wasn't going to work there. Could have been something totally out of my control. But then there is implementation failure, where there's something about how we scaled the practice, our implementation strategies, maybe, that just did not lead to success. So the intervention was great. Our implementation was not great, right? And so I wanted to really look at these two things and measure them, which made a hybrid type 2 really a perfect match. So we have COPD care, our intervention. We made this virtual training package. This was all before COVID, by the way. And so sort of lucky we made this virtual, right? And we wanted to measure patient outcomes, but also the clinician, the clinical teams, and how they view this package is affecting their abilities, right? And Dr. Proctor has these implementation outcomes. So, acceptability. Do staff members like this? Adoption. Are they willing to try it? Is the fit appropriate for the local area where this is happening? How much does it cost, right? Is this actually feasible? When the program's delivered, is it being delivered in a manner with high fidelity? Is it being implemented as prescribed or as desired? Penetration, how broadly are we able to implement this practice, and can it be sustained? So I had a lot of questions from these implementation outcomes, but I knew we had to refine the training package. So I refined our virtual training package. Here's a screenshot you can see. Oh my goodness, we went crazy on this. We made new templates that are like point and click, very easy to fill out. Case worksheets, right? So we had cases so that we could really work through real context-based examples for clinicians for how to manage COPD. We built a new action plan for patients so that there were nice new handouts we could use. And we made quick guides for each clinician involved for different workflow processes. And most importantly, we used video modeling. I really learned early on from pilot testing this work that clinicians wanted short 2-3 minute long videos actually demonstrating the practice in real time. And we made those, right? So the idea here was it was an extensive amount of effort, but I always thought it was worth it because we had a great team doing this. And it was all about the training, the informatics, and the workflow working in synergy. They all need to build upon themselves to really make this a seamless process, right? So here's how we deliver the training. It was over 4 phases. We engage with pharmacists, nurses, respiratory therapists. And phase 1 was a service overview. So what is COPD care, right? Phase 2 was all about this action plan and handouts for patients. Phase 3 was focused on disease state management, and phase 4 is all about logistics of delivering the practice. Now, what was unique about this was we know clinicians are really busy, right? And so we had these short videos, short phases. And what we did was we had the clinicians complete this on their own time when able, and we had debrief calls. So, we would actually have the group of pharmacists complete the service overview module. We had a 15 to 20 minute debrief call where we got to know them, ask questions. I was over here in Madison. They were in the Mid-South, and we were doing this work. Same with nursing, respiratory therapy. So it was a really unique implementation model we used at that time. What I didn't expect to happen, that happened very quickly because we had the best community partners. This was such a great facility in a great area of the country, just amazing problem solvers, and the can-do attitude, right, was so strong there. We formed a really great culture, right? It was a real culture of innovation around COPD care. And I knew at the end of this, every single staff member that completed the training, I knew about them. It was so fun. And they were able to support us going on site to do some in-person training as well. We brought this, all of us would love this, right? We brought pounds of cheese curds in our suitcases. It was ridiculous with ice packs. And they loved the Wisconsin cheese. They also made us a cake, which was so nice. So again, this is that idea of community-based participatory work and just engaging with wonderful people. That was really there, which is awesome. So then it gets into, well, how do you assess this, right? So this was a 2-year thing. We had our training in year 1. We delivered they delivered the practice in year 2. So we had a go live date in between. And when we thought about our clinical teams, I wanted to measure at baseline, how are people feeling about this practice? At go live, how are people feeling? That would help us understand the training period. And then a year later, right, the effect of implementation itself, how are individuals feeling? And I had a series of questionnaires, and all were agreeable to taking these. It was optional, but they took them. Theory of planned behavior. So thinking about how likely are you to implement a COPD practice into your workflow. Self-efficacy, managing this disease, right? Engaging patients with COPD. And also I made some questions too, just focused on the service itself, very detailed questions about the service. Interestingly enough, I put a questionnaire in there about telehealth because we didn't cover telehealth at all. Nothing about our intervention involved telehealth. And I wanted to do that as a measure of discriminant validity because I wanted to see, are we really moving the needle, or, because we'd anticipate telehealth to not do much, right? We didn't talk about it. So these were validated tools that were modified, with the exception of the 5th tool, which I made. So I really wanted to answer some questions very focused on the practice. You can see an example of how we modified the tools, really minor, like adding on COPD care at the end of a question. This is just an example. So let's look at acceptability, back to our implementation outcomes, right? Acceptability, appropriateness, and feasibility. Here you can see the 2 different sites, and we engaged with pharmacists, nurses, the years in practice. There was a real broad range of individuals with various experiences in practice, right? When you look at this. So here's what we saw, and it was really, really interesting. So we have our pre-training in green. We have our immediate post-training, so a year later in orange, and then a year after, reflecting the practice and the go live work in blue. And I should mention, between the go live and a year later, there wasn't a lot of intervening we did. It was more just, you guys are running it, and that's great, right? So we had significant improvements, which was exciting, from baseline to after those 2 years. And in a lot of cases, we actually had a significant improvement even in that first year, which was really neat. And look at that poor telehealth scale, right? Didn't do anything. So that was really promising, right? That the scale that had nothing to do with what we were doing didn't change, right? So that was pretty neat. Some fun quotes. So we did an audit and feedback session a year later, and during that we asked some questions as well. So motivation was a big factor in this, and I love this quote. "This has been ridiculously awesome. It's been extremely fun to do this training. I can't thank you enough. Training approach. I really like the videos." This was really great because that was feedback we received in Madison that actually translated nicely to our implementation. The real world appointment, like the real setting, you could feel it was a real situation. And then this patient-centered one, I love this one. "I still talk to the patient. I don't really need to anymore, but he likes to call to ask me these medication questions." So there's this relationship building, which is really, really exciting. All right. So now let's go back to our implementation outcomes and talk through adoption and fidelity. So we looked at retrospectively, right, some of these charts, and wanted to ask the question of thinking about the characteristics, the qualities of our work, how is this being delivered? And you can see in red, these are visits for COPD care, service components, the idea of patient empowerment with action plans being issued, optimizing treatment. And here's the pre-period in blue, right? So we could see that actually the program was being delivered as intended. And I think that the training, the informatics templates, the motivation nicely allowed for this. So this was a promising thing. But then again, true to the hybrid type 2, let's look at some of these patient outcomes. So this is a separate evaluation. It was the same project, same implementation, but a separate paper, a separate evaluation, looking at effectiveness, right? So we looked at 30-day readmissions, timely access to care, which I thought was really important for that initial pilot, and best practice delivery, right? How are we implementing these best practices? So this is baseline criteria, and this is COPD care, this is standard of care. And a few things I'll point out here is, our patients in the COPD care group in the year prior to the service had a greater number of exacerbations. And In pulmonary medicine, we have this saying, the greatest predictor of a future exacerbation is a prior exacerbation. So looking at this, our patients seem to have a greater likelihood at baseline of having exacerbations and hospitalizations as well. So that was just something to note. COPD is also graded based on disease severity, and our patients also were more likely to have, or we say trends towards would be better, more severe disease. Regardless, I'm just noting this for you so you can see. Here are the interventions, right? So like inhaler technique correction, tobacco management. And this was really exciting to me. This was what I really wanted to know, actually, was when we implement this practice, are we able to deliver best practices at a higher fidelity? And compared to standard of care, we can see, yes, we were, right? And that was exciting because the goal of this really is to improve care during visits for patients. So that was great. Referrals, comorbidity management, the action plans, med interventions all occurred, at a higher likelihood. We did measure readmissions, and we actually did see a reduction, right? So hospital and ED visits went down from within 30 days from 29% to 14%. COPD specific readmissions went down by 10%. And this was exciting. But again, the thing I really wanted to look at was follow-up, because this is something that, we do have direct control over with the program. And we saw 92% of patients were seen by either their primary care provider or pharmacist within 30 days, compared to 49% of patients in the comparator groups. This was really neat to see, right? So we're making an impact. Then it gets into, right, I had this whole experience and met amazing people and learned so much about D&I and applied these frameworks. And then it was almost like taking a deep breath and going, okay, wow, like what's next, right? And that's where my team and I set a really ambitious goal. And this kind of sounds crazy when you read it, but hey, we're kind of crazy, maybe, or maybe I must speak for myself. So before, with this experience, we scaled to one VA. We did it in 12 months. We had over 50 hours of meeting. We had an on-site visit. So it was great, but it was time intensive. And what we wanted to do was change that to scale to 5 to 8 VAs at a time over 5 weeks, with 5 hours total of meetings, and do it all virtual, right? So an ambitious goal. And the recipe to success for this, I thought, was implementation facilitation. And my team agreed, and I had some really great collaborators and team members involved in building this out. So we were a great team. But the idea behind facilitation, it's all about building new clinical teams that maybe didn't exist before. And there's 2 types of ways to do this, right? So one is internal. So at each VA medical center, building these networks, right, locally, to support and overcome barriers. But the other type of facilitation I was really excited about was external facilitation. So how can we actually build new networks outside of each VA medical center to problem solve, to overcome barriers, and to make this a seamless transition to implement COPD care? So what we did is we built in virtual discussions across VAs. So we made this a cohort experience, multiple VAs with leaders doing this at the same time through external facilitation and virtual discussions. We took our clinical training and we actually packaged it in a way that an individual at that VA could lead the training. It was all packaged, videos were there, and it was a train the trainer model, allowing for the VAs to control their own training, but have it packaged for them. We took that informatics support and we made it very quickly available. So rather than each VA building their own informatics resources, we nationally approved our templates so that they could be downloaded in a matter of minutes. And I think also what's important is this idea that, and this was a big realization for me, just speaks to our growth, right? Like I always do evaluations and go, oh, I really should have done this, but I didn't, right? So when I initially scaled this practice, we focused all on clinical training, and we totally missed the idea of what resources are we giving the implementers, the leaders that are doing this, right? Like we need to build a separate training package just for them. And so we did, And the goal was to take those barriers and knock them out, right? That's the goal. And so we built this COPD Care Academy with 4 workbooks. This was all for the implementers. It had nothing to do with the clinical work, although we referenced clinical work, but this was for those implementing the practice, the leaders on the ground doing the work at each VA. And we had email templates. We made this a big part of this is culture building, right? So we had certificates of completion. We even made a YouTube video dancing with balloons in the background, right? Which was crazy. And we had these national tools available so that sites didn't have to recreate the wheel when doing this work, right? We had a train the trainer package for clinical work, templates, a dashboard to identify individuals. And we use this to scale now to over 49 medical centers, right? So it was really exciting that, what started as something in one clinic, right, at one VA was able to be scaled so rapidly. And, now I'm leading the evaluation work for this practice. I'm no longer involved in implementing it, right? But it's great to see these tools still being used. And so, of course, the DNI, as a DNI like enthusiast, right, I wanted to know, how is this training package that was used to scale this working? And so I leveraged a framework called REAIM. So the reach, how well is this program reaching our clinical teams? How effective is the training package on promoting clinicians' own self-efficacy and their perceived capability to actually implement this program? Adoption. So are sites adopting this training that we built? How are they implementing this, right? So like, what's their acceptability of the practice and the training, the appropriateness, and finally sustainability? Like, are these tools being used beyond our 5-week sessions, right? So just for effectiveness, because we don't have time to go over all this, right? So just for effectiveness, we did a questionnaire, before the academy, after, and we asked these questions like, rate your capability to launch a COPD program, to form collaborations with your colleagues, right? And we did see a lot of movement there, which was reassuring to me that, okay, I think we're actually moving the needle here, right? And so that was exciting. And, now it's all about translating, right? And so part of translation, I think, is digging deeper into what you're already doing, right? So we've done some REAIM work looking at COPD care, and part of REAIM is this framework PRISM, or you could say part of PRISM is REAIM, right? But the idea is like, what's going on the ground, not just from the perspective of the implementers, the leaders, but from other individuals, the clinicians, the C-suite leaders, the patients, right? Like, so really learning from colleagues with different perspectives, with different lived experiences from this practice, and understanding in a deeper sense, what is it that's leading to these changes or isn't leading to these changes? What are the site-specific contextual factors, right, that are influencing this program? So that's where we're at now, right? We're looking at this, and we're also, in a true hybrid 2 model, right? We're also looking at effectiveness in rural communities for this practice to understand, how is this practice impacting rural patients? We're always trying to learn. It's a cyclical process, right, of learning from the clinical teams, measuring effectiveness. We all ask ourselves, right, what do we do right? What do we do wrong with this assessment, and making it better? One thing, though, has stood true throughout this experience for me, and always will. And, it's partly because I am a clinician, I practice, right, in pulmonary medicine, but it's about the patients. Like, this has always been about our veterans, right? And how can we optimize care for them? How can we deliver best practices with high fidelity for our patients, so that they can receive better outcomes, whether that be access to care, whether it be symptomatic improvement, but that's always been our why, and continues to be throughout the journey. So with that said, I was told 40 minutes, and at 46 minutes, so I'm a little over, but I again just really want to thank everyone for their willingness to attend today's session, their interest in the work. I want to thank, all the mentors that have made this possible within VA, within ICTR, the Launchpad. I think the reality is, the University of Wisconsin-Madison is a very special place to train and to work. There's a unique culture here of innovation with D&I that I think really fosters this type of work to just organically happen. And I'm very grateful for that. So, okay, I'll stop talking now, and which will be welcomed, and open it up for questions or comments or anything.
Thank you so much. This is just amazing.
Thanks.
I'm just beaming with what you've done. I'm going to start out maybe with one question, and then I'm sure we'll get more in chat. I'll start with what I think is the most important question, which is, this is really, you have shown how this can be done. Do you think this is something that these methods, almost the key elements of scaling up an intervention, a team-based intervention to improve health in a clinic setting, do you think that you could use these key elements pretty easily? Would it be transferable to like congestive heart failure care, some other, major types of care that require team-based planning and integration of best practices?
I do think so. I do think so. And I think specifically the way that we've used facilitation, like that idea of how to actually implement the practice, you could sort of plug in different diseases there, right? Now, of course, when you do that, what ends up happening is you may have different stakeholder pools. So certainly there'll be some different barriers that occur just because we may be changing what types of service lines might be involved, right? But I do think that the general structure of leveraging external and internal facilitation and really minimizing these informatics barriers, right? And providing that package training, I think that can be tested and should be tested, right? For different disease states in the VA. Absolutely.
Very cool. I'll let you look at chat if you've got
I'm
got a
always
couple questions.
So bad at looking at chat. I'm sorry about that, you guys. Okay, let me see. How do I?
Can you see there's one from Jason?
Yeah, let me try to stop sharing here. Hold on a second. Where is my share? You know what's weird is like, for some reason, my stop sharing thing is like not showing. Yeah, could you possibly read the question? Then
I will.
Sorry about that. Okay.
The first question is from Jason Vanstone. Great presentation and initiative. Do you have any insights on some of the barriers to implementation that were experienced across the different facilities?
Oh, yes, absolutely. What's been really interesting, so many barriers, right? This is like, I always joke, like D&I is like, it's such a messy, you have to have a degree of being comfortable with messy work that can't be pre-planned, right? Because that's part of it. I'm doing a lot of work right now in rural settings, and some examples that are unique, one being not every VA has a pulmonologist, right? A pulmonary service on site. We have instances in rural settings where some patients, when they do have exacerbations, will seek care in a non-VA community hospital. And so it can be harder to track or know what's going on in those settings and get them integrated in the practice. I think one of the other really promising things, though, about rural has been that when you have a really effective clinical champion who knows the clinical teams well in their rural setting, they can get an amazing amount of work done and really build an exciting program. So, interestingly, some of the barriers we're seeing in VA and rural really mirror what we see in the literature about, limited access to or distance affecting care delivery. Telephonic care really helps with that. Less access to specialists. And those specialists can be really important for us in COPD care because, in primary care, once a patient reaches a certain point, they'll need a specialist involved. And when that person's not there, it becomes hard. And that's a challenge across the country for non-VA care. I think the VA is actually ahead of the curve with that because of the infrastructure of the VA, but it becomes an issue. So there's a few examples there.
That's fantastic. The next question, I'm just going in order.
Yeah.
You have like 3 or 4 great questions.
Oh gosh, thank you. Yeah.
From Christy Bartles, how do folks enter the D&I research community at the VA?
Oh, that's an interesting question. And that's a great question, Christy. Thank you. So my entrance was a little unique, right? Because when I through VA D&I, when I was doing the work with the Diffusion of Excellence Office, part of that program, which is a really exciting program, is they totally get it, right? This idea that you take these innovative practice ideas and you pair a healthcare leader with someone with a group that has a lot of dissemination science experience. And that's what happened with me, years ago, as I started working with some of the folks at the VA Query and other groups within VA to really build this out. And that sort of has happened as a part of that Diffusion of Excellence program. There are in the VA really awesome hubs for D&I. And, for example, I collaborated with Dissemination colleagues in Little Rock who are amazing to build out some of this facilitation work. And just having some of these meetings, right, with thought leaders really helps help me at least to guide my approach and to familiarize myself with a topic that I maybe didn't have as much experience with before starting. So, I think the entry to D&I may be different for different people within VA. But credit to the VA for having that infrastructure there and to have the right partnerships in place. Thanks for the question. Yeah.
The next question is from Amir, and I'm not sure.
Great.
Do you know Amir? Azizian, I believe.
Uh-huh.
And he's keen to know if the identification of implementation determinants is incorporated into the COPD care workbooks. And there's a second question with that.
Yeah.
What about non-clinical determinants of health, social, structural, et cetera? Are they embedded in the implementation strategies, for example, the workbooks, et cetera?
Yeah, that's a good question. Can you read the second part to that again, actually? Because I want to answer that one first. That's okay.
Okay.
Yeah.
I'm also interested in knowing if non-clinical determinants of health,
Yeah.
i.e. social, structural, et cetera, are embedded in the implementation strategies.
That's a good question. And I would say what we've done within COPD care is we've taken a lot of the work that the VA has done to consider social determinants of health, right? And we've tried to build that into the practice itself. So, a lot of these interventions, I don't take credit at all for for making, right? So for example, the VA has a program called MOVE, right? And it's all about improving exercise opportunities and diet for our patients. So the VA has really strong tobacco treatment clinics to help our patients minimize or even quit smoking. The VA has really strong networks with pulmonary rehab centers, right, to try to help our patients with COPD improve the accessory muscles around their airways so that they can breathe better, right? And so one of the things that I tried to do with COPD care is really make a list of what are these resources available within VA and how can we really seamlessly incorporate those resources into our referral process for the visits. So, for example, in our template, what I did is I have like these check boxes at the bottom for like home rehab or vaccines or whatever it might be, and including pulmonary clinic, right? And as clinicians click those, and when they sign their note, the referral actually comes up on their screen and they can just accept it. So it's really, for me, it's been about taking resources that someone else with, brilliance built, right? And just trying to make it easy for clinicians when they're so busy and there's so much going on, right? To find those resources and sign those orders when appropriate so that we can integrate patients more effectively within that VA infrastructure that is focused on that type of care delivery. Does that help answer that part of your question?
I'm not sure if he can.
Yeah,
And I
yeah,
think
yeah.
I'm gonna skip ahead.
Okay.
Oh, wow. Amir's joining from Saskatoon.
Oh my gosh, that's amazing.
Very cool.
Wow, I'm honored. Thank you. Yeah.
That's great.
Jeez.
I
Yeah.
want to skip to ahead to one other because this is probably the last one we have time
Oh
for.
yeah.
And I encourage others to reach out to Ed separately.
Yeah, happy to. Yeah.
And maybe you want to put your email in chat,
Yes, no problem.
or somebody else can.
Yeah.
What would be the main changes you think would need to be made to adapt to non-VA clinics?
Oh, I've been thinking about this so much. Oh my goodness. Okay. So um I think one of the major shifts that has to occur is the funding model, right, in the private sector for team-based care. Now, some of that's already happening. So for example, in Wisconsin now, and this just happened in the last year or so, pharmacists are able to bill for services under Medicaid. And that's a big deal because that now changes how we might be able to practice to stay afloat, right? As in our clinical work. So by having that reimbursement opportunity, that's a new incentive and approach to integrate pharmacists within primary care teams. And we see, larger academic medical centers having pharmacists on the care team. We're seeing that more and more and more. But I think the reimbursement change now allows for more rural health systems to consider bringing pharmacists into the care team more. And it's happening every day, but it's happening more and more now. And so I think as these reimbursement models continue to shift to really embrace team-based care delivery, this becomes more and more feasible. I actually am really excited about the prospect of translating this work. And I think it's just another opportunity for me to engage with my mentors and, try to really wrap my mind around how that might look. But I think reimbursement is step one of that. And it's just in the last year, there's been more incentives to make this happen, which is great. So I appreciate that question. Oh my gosh, so much to learn, right? Thank you. Yeah.
Absolutely. Well, I'm going to close this up here. And just say thank you to you again.
Oh,
And what a great ending to our DRISS seminar series for this year. And there was an evaluation link we put in chat, and we'll also send out a follow-up email next week that includes the evaluation link and information about our YouTube channel, which hosts recording of the DRISS seminars. And we want to let you know that next year, 24-25, we will be focusing on recruitment science. And it'll be DRISS Presents focusing on Teach RS, recruitment science, which is going to be really about how to use implementation science to enhance recruitment, which should be really cool.
nice.
The second Friday of each month, noon to 1, starting in August, and save this date in your calendar for next year. And thanks again, Ed, so much.
Oh, it was such an honor, really. And thank you all for your time. I'm really grateful that you were able to join today. And thanks, everyone, again. So take care. Have a great weekend. Happy Mother's Day to the moms. Thank you so much. All right.
Yeah.
Gotta say that. Thank you so much. All right.